In this video, I will talk about Fanconi syndrome. What is Fanconi syndrome? Fanconi syndrome is a defect in the proximal convoluted tubule. It is a renal tubular defect which is autosomal recessive in manner. But first, let's talk about the normal physiology. What is the function of a normal PCT? PCT is very active, which reabsorb about 65% of total sodium. So sodium goes from here to here by passive diffusion because the tubular fluid has high sodium load than the cell. That's why sodium enters from the luminal side into the cell by passive diffusion. Again, sodium goes from here to here by primary active transport. In this case, there is a sodium potassium pump along the basolateral surface by which sodium enters into the blood and in exchange potassium enters into the cell. Chloride and water follows the sodium. Chloride is reabsorbed in the blood by electroneutrality law and water by osmosis. Again, some sodium enters into the cell by passive diffusion from the luminal side and it takes glucose, amino acid, calcium and bicarbonate along with it by secondary active transport. The energy that is required during this process is derived from primary active transport. Glucose goes from cell to blood by facilitated diffusion through Glut2 transporter. Carbon dioxide diffuses into the cell through the luminal surface, which with water produces carbonic acid. Carbonic anhydrase is an intracellular enzyme which breaks down this carbonic acid into proton and bicarbonate. So our body produces acid in metabolism and our body tries to get rid of it by two ways. One by secreting it and takes sodium in exchange through sodium hydrogen exchanger and also by reabsorbing bicarbonate through basolateral surface. Never forget that Fanconi syndrome and Fanconi anemia is different. Fanconi anemia is a aplastic anemia. So what are the causes of this Fanconi syndrome? It may be due to inherited condition or due to acquired. In the inherited, the most important is Wilson, which occurs due to accumulation of copper. Then von Gierke, which is a glycogen storage disease. Then tyrosinemia, cystinosis, which is common in children. Another one is galactosemia and hereditary fructose intolerance. Now it may be acquired due to heavy metal poisoning, mainly lead, and multiple myeloma due to paraprotein. Among the drugs cause, it may be due to aminoglycoside like gentamicin, amikacin, and tetracycline, mainly expired tetracycline, and cisplatin, also antiviral like tenofovir. So normal PCT versus Fanconi syndrome. Normal PCT, reabsorption of sodium, and in Fanconi, failure to reabsorb sodium will lead to hyponatremia. Failure to reabsorb potassium will lead to hypokalemia or increased urinary potassium excretion. Failure to reabsorb phosphate will lead to phosphaturia. Failure to reabsorb amino acid will lead to amino aciduria. Failure to reabsorb glucose will lead to glycosuria. Failure to reabsorb bicarbonate will lead to metabolic acidosis. In this case, there will be normal and uncapped metabolic acidosis. And in normal PCT, the secretion of hydrogen occurs. And in Fanconi, this hydrogen cannot be excreted. So the accumulation of this acid or hydrogen will lead to renal tubular acidosis. So mainly type 2 renal tubular acidosis occurs in Fanconi syndrome. So what are the symptoms of Fanconi syndrome? Symptom like polyuria. Due to polyuria, there will be extracellular volume depletion, which will lead to fatigue and low total body sodium. Due to low total body sodium, there will be dry skin and dry mucous membrane. Due to loss of isotonic fluid and patient take drinking water, plain drinking water, which will lead to low sodium level or hyponatremia. And sodium is related to CNS function, so there will be low CNS function. Glucose very important for growth and thrive. So due to glycosuria, there will be fatigue and failure to thrive. Due to loss of calcium and phosphate, patient will show the features of rickets in case of children and osteomalacia in adult. Due to hypokalemia, there will be muscle weakness and fatigue. How can we diagnose? In blood, everything will be low. low sodium, low potassium, low phosphate. As they are excreted in the urine, their ratio in the urine will be high. Due to loss of fluid and volume depletion, the renin will be high and aldosterone will also be high. So there will be high renin aldosterone ratio and normal and uncapped metabolic acidosis. Treatment is basically the treatment of the cause and replacement of the lost electrolytes. In the end, if I want to give a quick mnemonic, we can remember by Fanconi. F for failure to thrive, A for acidosis, mainly type 2, N for nutrient loss like glucose, amino acid and phosphate, C for the cause like cystinosis and cisplatin, O for phosphatidiuresis of symptom like polyuria and dehydration, N for nephrocalcinosis due to calcium hosting, and I for anion loss like sodium potassium bicarbonate.